Good evening. Welcome to all of you, and thank you for joining us at the end of what's undoubtedly, for almost everybody here, been a very long and brain-filling day. This, for those of you joining us from the great beyond, is day 3 of the annual meeting of the American Society of Tropical Medicine and Hygiene here in rainy Baltimore. And this special panel is being broadcast via Facebook Live. So if you would like to join the questions and comments after we've spoken for a while, please do so. You can reach us on Twitter. It's Twitter at @stop_pneumonia. I'm not going to spell pneumonia because everybody in this group actually knows how to spell it, which is a really unusual subgroup. So you can, if you forget that extra letter, you can look it up. I'm Cynthia Gorney. I'm a writer for National Geographic magazine. I am greatly in debt to everybody who's on this panel, because about more than a year ago now, I was asked by National Geographic to do, and it was this broad a mandate, an important vaccines piece, they said, for 2017. You go figure out what you think is important. I did not come into this with experience in vaccines. This is not particularly my specialty, which in a way made me a really good candidate for this, because I think I'm pretty reflective of the general level of ignorance, as well as perhaps belief and some superstition that's out there in the lay public in the vaccine area. And after a lot of desperate phone calls to people like Dr. Klugman and people at IVAC who were fantastic in their help to me, just saying, please tell me everything I need to know about everything, give me some reading to get started with. We went through a number of stories that most people in this room will understand why we discarded. When I told my friends in the East Bay that I was doing a vaccine story, of course, everybody immediately said, oh, you mean about anti-vaxxers and vaccine hesitancy? And I said, no, been done. It's important, but there are other things that you're not nearly as aware of that are actually far more important. And with the help of, in particular, as I said, the IVAC and Johns Hopkins experts, I was directed to the large and very important matter of pneumonia, pneumococcal vaccines, pneumococcal conjugate vaccines, and perhaps most fabulously from my reporting practice, Dr. Shamir Saha, who's sitting at my left, who was one of my very first phone calls. And for those of you who know Shamir personally, you will understand why, after he's been speaking for about 8 minutes on a Skype conversation, I said much more politely than this, shut up, I need to come see you. Will you be the center of my story? You're perfect, and we'll talk later about why, but I am just extraordinarily grateful to him and all the other experts for the guidance they gave. So we're going to talk this evening about pneumococcus, about pneumonia, and also probably more generally about the importance of telling not only the best known vaccine stories, but the right vaccine stories, the more helpful vaccine stories to the general public. So I hope that your questions and comment will span that whole range of issues. I know I'm talking to a room that includes people of tremendous expertise, so it's pretty daunting to be up here in front of those of you who have actually spent a lot of time in laboratories learning far more about this than I will ever be lucky enough to know. But let me start by just introducing very quickly the panelists. Then I'm going to ask each one of them a question that I hope will get us rolling. Let's see, to my right here, Dr. Cynthia Whitney is the CDC's Chief of Respiratory Diseases Branch at the National Center for Immunization and Respiratory Diseases. Dr. Keith Klugman is the Bill and Melinda Gates Foundation Director for Pneumonia. At the end, Dr. Chizoba Wonodi is the Nigeria Director for IVAC here at Johns Hopkins. Here we have, just to her right, Martha Rebour, who's the Executive Director for an organization called Shot at Life, which she will explain, with the United Nations Foundation. And of course, to my left here is Dr. Shamir Saha, this is going to be a long title, folks. He's the head of the microbiology department at Dhaka Shishu Hospital, which is the biggest children's hospital in Bangladesh. He's the executive director of the Child Health Research Foundation in Bangladesh, and he has just been awarded the UNESCO Carlos Finley Prize in Microbiology for important contribution to the field in Paris, and he Zoomed from Paris here, arriving about 45 minutes ago with rain all over his suit jacket, so extra kudos to him. And this comes on the heels of a previous 2017 award from the American Society for Microbiology for research in clinical microbiology. So extra lucky to have Dr. Samir with us. And I feel personally grateful to get a chance again to spend a little time with him. Dr. Whitney, I'd like to address my first question to you. You've been working in pneumonia with a broad view in your position at the CDC. You're talking to a room that includes people with great expertise, not necessarily in pneumonia, not necessarily in respiratory illness. And I'd like you to tell us what you learned more recently that seems to you the sort of most important news that these folks with expertise in other areas might not quite fully have digested.
Okay, thank you. One thing I'd like to mention is that well, actually, maybe I'll go with two things.
Okay.
First of all, a lot of my work has been on pneumococcal vaccines, so we'll start there. And we're learning when you vaccinate children against pneumococcal disease, they stay healthy themselves, but they also stop transmission to other children, to adults who maybe aren't vaccinated. These are called indirect effects. We saw this in the United States when we introduced vaccine. We're now seeing it all over the globe. The other thing is when you prevent that first episode of pneumonia, I think it's keeping children healthier. So I think you're preventing other pneumonias, maybe you're preventing diarrhea. I think if we can use measures that keep children healthy in the first place, whatever they are, it's gonna, prevent all sorts of disease.
I'd like to, Dr. Klugman, I'd like you to follow that up. You've been studying pneumococcus in particular for decades, pneumonia and pneumococcal pneumonia. I'd like to ask you sort of a two-part version of the same question. What do you see as the development most significant for this audience of people with great expertise to know? Second, for those, again, in this audience who may not know, why did it take so long to get a pneumococcus vaccine that would work well for children?
Good. So yes, with pleasure. So this is a meeting focused on disease burden and trying to prevent the largest killers of children and adults in the world. So it's focused on tropical medicine, which basically means medicine everywhere around the world with mostly poor people. And unfortunately, as far as children go, the major killer of kids is pneumonia. Now this is extraordinary because pneumonia, as you'll hear in this session, is preventable. It's also treatable, and very few people even know how to spell it, as you pointed out. So pneumonia is a big deal, and we're actually on the cusp of World Pneumonia Day. So this gives an enormous opportunity to bring the problems of pneumonia to the world. So we do have now a vaccine, which, as you pointed out, has taken a long time to get to the developing world. And as Cindy pointed out, the CDC here in the US really did fantastic work showing that not only were children protected when they got the vaccine, but it stops transmission in the whole of the United States. So the strains that are prevented in the vaccine in children are no longer causing adults to be hospitalized with pneumonia. And so we at the Gates Foundation are particularly interested in seeing whether that's true globally. So we're supporting studies around the world, and at the moment it is looking like we're seeing the same thing. So that in developing countries, when children are immunized, adults too are not hospitalized with pneumonia, and there are many reasons for pneumonia in the developing world which are not particularly common here, such as HIV. So HIV is the biggest driver of pneumonia, say, in South Africa. And their hospitalization for HIV-infected individuals with pneumonia has gone down since the kids started being immunized. So that is really good news. The second part of your question was why so long to get to the developing world? And unfortunately there, it's all a question of cost. And so there was a remarkable financial investment made in getting this vaccine into the developing world, which has reduced the cost of the vaccine dramatically to around $3 a dose. Unfortunately, that's still too expensive for the poorest
let's
countries.
remind people that it's not a one-dose vaccine.
It's a 3-dose vaccine, so it's up to just under $10. We would like to see that fall below $5 for the course. And so we at the foundation are doing everything we can to look at avenues to reduce either the number of doses that have to be given or to try and help the development of less expensive vaccines.
Okay. To Ms. Rabur, explain Shot at Life, if you would. Explain the impetus behind it. And I have one other question I'd like you to address. We'll talk more about this later. But where do you find the greatest obstacles? What kinds of arguments do people toss at you when you come at them with the Shot for Life campaign? Okay?
Okay. So first, just for a quick explanation, Shot at Life is a campaign of the United Nations Foundation. The United Nations Foundation was founded 18 years ago by, we call him the philanthropist, Ted Turner of CNN fame. At the time, he was very close with Kofi Annan and very frustrated with the U.S. being in arrears of its dues to the UN, and he said, you know, I'm going to pledge $1 billion to the UN. And at the time, Kofi Annan said, well, we can't take your money, Ted, but maybe you could form a foundation. So 18 years later, the UN Foundation supports the work of the UN on a sort of a comms front, but also under different verticals. So about 5 years ago, Shot at Life was founded, and Shot at Life is a grassroots advocacy campaign. So we're a campaign that's focused on helping reduce the number of children who die from vaccine-preventable diseases around the world. It's sort of a simple proposition. If you think that there are more than 1.5 million children a year who die from a vaccine-preventable disease, and especially when vaccines, apart from the pneumo vaccine, but in general, vaccines are really pennies on the dollar. So it's incredible investment, and it's so exciting to hear about, you know, stopping pneumo transmission among children also helps protect vulnerable adults. So vaccines are just a wonderful investment. So Shot at Life was founded a little more than 5 years ago with help from the Gates Foundation. And we do a few different things. So as I said, being grassroots advocacy, what was recognized, and the reason why UN Foundation is based in Washington, D.C., is the U.S. government invests hundreds of millions, up to $2.5 billion on a lot of these programs. So it's very important that their members of Congress are hearing from their constituents about how important this issue is to them, and to make sure that we shore up very strong congressional support, because it's critical that the investment is there sort of on the U.S. government side. And then we also do other things around raising awareness, and we have partnerships with, if any of you have been at the conference and you saw the Walgreens clinic, so there's a flu clinic that Walgreens set up, and they have a program called Get a Shot, Give a Shot. So if you go to a Walgreens and you get a flu shot or other immunization, through our campaign, they will donate to protect a child around the world.
And
so that was a long answer.
But no, but I want to know when people.
Yes. So the obstacles.
It sounds to this group like apple pie and motherhood.
Yeah.
You know, help prevent vaccine-preventable diseases. When people say no, what do they then say?
Yeah. So I have to say there was some hesitancy when the campaign launched about what was going to happen with these anti-vaxxers, and it's perhaps a little bit of a cynical point of view, but a lot of them said, well, if it's, you know, children over there, it's fine. We have not had a lot of resistance, in fact, from the sort of...
Wait, if it's children over there, it's fine to give them vaccines? Not it's fine that they're dying at a rate of 1.5 million a year?
No, it's fine for them to have vaccines. Okay. It's my child, which again, I find to be a very cynical point of view, but it's sort of like, well, for my precious child, I want to space them out more, or I'm not sure of the safety. So I think, but to be honest, we have had very little resistance or people coming to us. I think we're very good about sharing numbers and sharing, you know, I think when people, there will always be an anti-vaxxer community, and I think we don't focus on trying to change anyone else's mind. We're a very positive, forward-looking campaign. So
good. Okay. Dr. Wanodi, so these are, I think almost everybody in this room is a scientist or a physician or a policy expert or an extremely interested person here. So for reducing the pneumonia burden generally, what should they know, particularly from the perspective of a Nigerian physician?
Well, I think that our experience in Nigeria, and you alluded to it earlier on about why the delay in adoption of the vaccine. Our experience is that the fact that these interventions exist doesn't mean that all kids will have access to them, even within the country. So pneumococcal vaccine, for example, was introduced in Nigeria in 2014, December 2014, and then there was a phased rollout of the vaccine across the 36 states and federal capital over a period of 2 years. And since pneumococcal vaccine has been introduced, we've not really been able to get the coverage high enough. So a recent survey came out that indicated that the pentavalent 3 coverage, which tracks very closely with the PCV coverage, was on average of 33% for the whole of the country.
I'm sorry, 33%?
33% for the whole of the country.
Wow.
But the range, the variability within the country is what's also more interesting. So it ranges from 3% in Sokoto State in the northwest of the country to 80% in Lagos State, the southwest of the country. So there's a large disparity even within the country, even within one country. And then so it shows that just having the intervention is not enough. So we need to do much more. We need to do much more to ensure that kids have access to it. It's almost like the delivery of the vaccine itself should take preeminence. I'm glad that the introduction has happened, but we have to really focus on the delivery. What will it take to ensure that kids get these vaccines when it's in country?
So Dr. Saha, I'm sure those statistics were impressive and disturbing to you. We last saw each other in the workplace, your workplace, in January. At that point, you were looking with some optimism at early statistics for what the 2.5-year-old PCV coverage pneumococcal conjugate vaccine, for those not in this vocabulary, that's the children's vaccine, might be doing for your rates. So what I want to ask you is, first of all, do you have any more news? Is there any more cause for optimism or hope? And second, listening to what you've just heard about Nigeria, what does that make you think about the most important issues to lean on in countries that are still developing, that have health infrastructure problems to deal with?
Okay, thank you. I mean, I think I have to give a very special thank for the whole group, because Bangladesh is in focus in this, so it's very important for us, and thank you all. I think we have optimism. I think that's the reason we are making progress, and Bangladesh is also making progress. And I can tell you that we hardly see any vaccine type now.
You mean any vaccine type cases in the
vaccine
hospital?
type cases. We get, and you saw that we run a study where in every year we get about 100 invasive pneumococcal disease cases, and we know they are serotype. So, but the challenge, I think, no matter the way you wrote on the National Geographic, but most of the people here, they're experts, and they know about this. But at the same time, possibly here, we also should talk about what really we are missing. I mean, the policymakers, we all are very happy, in fact, the vaccine is working perfectly. We don't see any vaccine type. But policymakers will not ask us, okay, what happened to the vaccine type? They don't care about the vaccine, impact of vaccine on the vaccine types. They want to see it as a whole. So that's what we're looking for. Our country has no challenge like this, because our vaccine coverage in the population is more than 90%.
Just to clarify for every person in the room, I would guess, who doesn't have quite the level of expertise in pneumococcus serotypes that Dr. Saha does, you might want to explain for people whose area of expertise is not here, what you mean when you talk about vaccine types here.
The pneumococcus has more than 94 serotypes now, and you want to protect all of them. You need really 94 different type of vaccines almost. But fortunately, the good news is that all of them are not really causing the invasive disease. The bad news is that in the developing countries, relatively diverse serotypes are causing disease compared to the serotypes in US and other developed part of the country. And that's why the initial vaccine was developed only for 7 serotypes and now 10 and 13 different serotypes. But we have more serotypes than this. Let me go back to this. The vaccine coverage is pretty good in our country, so that's not a problem. But still, large number of pneumococcal diseases are there. And with no vaccine, it is not that the vaccine, non-vaccine types, which I'm talking about, are coming now. This was there before. We need to discuss about this also pretty more so that the vaccines are not really misunderstood or undermined. The vaccines are doing what it's supposed to do. What we discuss now even more, what we should do next. Because pneumococcal vaccine is not like Haemophilus vaccine, Hib vaccine, that you give the vaccine and it is gone. This will remain, and we need to prepare ourselves. I think that's the discussion we should have with us as much as possible. Vaccine coverage is one, we can do this, but possibly this will take much time. Let me give you one example. I mean, Keith is here. We are always, when we're talking with Keith sitting there, then we think about this. Okay, serotype 2. We are talking about serotype 2 for a long time from Bangladesh. And people really talked about this, listened to us, and thought, okay, don't worry about this. So what? It's an outbreak. But serotype 2 here to stay. Serotype 2 in Bangladesh, still from 2000 to now, it is the most predominant serotype. It is now in North America. It is now in Israel. It is there. If we are not talking about now, that the best possible vaccine prepared by the industries will limit to those vaccine types. I want to bring before coming here, I thought what kind of question Cynthia will be asking me because I could not really communicate with them. But I thought I have to bring those things because my policymakers will be asking me that when I'll be going back to home. If I'm not prepared from now, the vaccine preparation or the next formulation of vaccine will take further time. And I cannot afford to see that more the children are having pneumococcal disease in the future. Nobody in the new formulation, the vaccine coverage can take care of by effort, in fact, but vaccine development is not really that simple. Some of those are mentioned in this article that how much time it takes, why it is so expensive. I have not seen that anyone is considering serotype 2 in this, but few other serotypes are there, 45, 8, those are also there in these countries. If we don't try from now, we'll be late, in fact, for the next generation vaccine. So that's what I'll be bringing up.
So don't worry, Samir. So
Okay,
the Gates Foundation is considering serotype 2. So I think Samir raised a really interesting point, and that is that he pointed out the first vaccine, which was made, only covered 7 strains. And because this is the place where people are rich enough to afford the vaccine, the initial vaccine was only designed essentially for America, for the top 7 strains. And there was another serotype called serotype 1, which is the dominant serotype in the developing world, which was not included. And a few people, myself included, insisted that we wanted to see a serotype 1 including vaccine. And such a vaccine was actually made and tested in Africa, and we showed it worked. But it then took another 10 years before it was included in the next generation vaccine. So indeed, when we look now at this problem that Samir alluded to, which is that there are remaining strains out there, and again, the drive will be to include a vaccine just for the remaining strains in the US or Europe, but it is the Gates Foundation's concern too. And as long as I'm at the Gates Foundation, we will be doing our very best to make sure that future generation vaccines include the critical additional serotypes, which at the moment would include also serotype 2.
One phrase that I heard frequently from people at the Gates Foundation as well as IVAC was upside down, as in the system is upside down, as in the system designs for return of investment, profit. And in this particular case, the people who need this product the most are the ones who not only cannot afford it, but the ones who suffer individually most dramatically once these infectious diseases hit them. So I want to ask you a question that sort of segues off of that, which particularly in your capacity as someone who cares deeply both about the Gates Foundation and about pneumonia and pneumococcus. It's not exactly a zero-sum game for the funding, but in a way it sort of is, right? There is a limited amount of money out there to hurl at public health. So how do you think about the relative importance of vaccine, development of future specified vaccines, as you've just said, and vaccine access, when you compare it to all of the other important scientific work that is underway and all the important work in infrastructure and so on? Where does vaccines come in?
So vaccines are an extraordinary public health intervention, and I think that there are lots of needs out there, but vaccines are way up amongst the most successful public health tools ever invented. And I actually want to point something out, that this is a complex issue, but in fact there are some very exciting opportunities. So in fact, this particular vaccine that we're talking about was developed essentially by two large multinational companies. And having said that the strains were originally designed for the developed world, the existing vaccine really has benefit globally. And so there are a number of ways for us to try and support getting these vaccines to the poorest of the poor kids. But in fact, it is ideal when the vaccine works in developed countries as well as developing countries, because there's no way to make vaccine really extraordinarily inexpensive if there's no market for it. So with the best will in the world, the really neglected diseases tend not to have vaccines for them. So in a way, we're fortunate that pneumonia is democratic, you could say, and that it causes disease everywhere. And that does give us an opportunity not only to invest with developing country manufacturers, but also to talk to the major manufacturers in the world and say, okay, guys, you can make billions of dollars selling this vaccine to the developed world, but make enough extra vaccine for the developing world, which you will make no profit on it. But I was discussing with someone today, I mean, there's a lot of wonderful people who work for these companies, and they will work better for your company if they know you're doing something good for the world. They'll feel inspired, they'll love working for the company. So you won't make money out of it, but there's a lot of reasons still to do it. And so that's part of our mission, to make that argument to the big companies. And to some extent, I hope that we're going to succeed in that regard.
I was going to say, how's that going so far?
Well, it's harder when there's already a vaccine out there, but there are a couple of bugs coming where we are actually helping to fund the initial vaccine, and we're hopeful that we can do this. So we have a number of ways to do it, but I am optimistic. Like Samir said, he's optimistic. I am optimistic that we will be able to do this.
So one important thing possibly here, most of the developing countries, we need to take care of the developing countries as well. And there should be data generated from those countries. What are the vaccine, what are the invasive serotypes are circulating? If we do not have that data, we'll be not really getting the right formulation. I still remember the vaccine PCV7 was covering only 25% when we first did the serotyping. And we named one, DACA9, which will be covering 70%. So many of those papers or the publications, you will see that the serotypes are together, are serogroups, and they're all considered as the vaccine allied types. That really will not work. So we have to make sure that we are getting the detail and giving the real evidence to Keith so that he can really work on implement those. We are lucky that that position is being held by Keith, in fact. So I know that if you look at the average turnaround time at Gates, I wish that Keith will remaining there for another several or many years.
I'm going to ask one more question, and then to Dr. Winody, and then I would like to open it up to the audience, because I know there are a lot of people in this room with particular expertise and interest, and anybody from the outside, as we said, who wants to tweet to @stop_pneumonia is welcome to do so, and we'll try to incorporate your tweet, if it's a question, into the discussion here. So my question is about something you alluded to when you spoke before. You've got to address these issues, you said, and by that we mean vaccine coverage and reducing pneumonia in general. not just within the health system itself. You've got to be more creative about that. Tell us what that means in Nigeria, for example.
Yeah, so you're right about not just being within the health sector. So pneumonia, for example, is a disease that thrives in the midst of misery. So for example, if children are malnourished, then their risk of pneumonia is higher. So there are some underlying poverty-related conditions that children face that make them even more susceptible to pneumonia. And it's not enough to just provide a supposedly magic bullet. It will not work. So we need to think about a more broad sectoral intervention. So we need to think about addressing malnutrition. For example, in Nigeria, it's it's really, really a crisis right now in some parts of Nigeria, particularly the northeast, where we've had insurgency in the last several years. Children are acutely malnourished, and it will seem disingenuous to just go give a vaccine to a kid that is hungry. So, and a lot of the times, the rejection that comes from communities is actually a rejection of the seeming insensitivity to the other pressing needs, the other more salient pressing needs of the community. So we need to think about it that way.
My child is starving, and
so my child is starving, or my child has malaria and fever, and all you just want to do is give, for example, a polio vaccine. And the intervention that has really changed the intervention. So in the polio campaigns, for example, they do more of what they call polio pluses. So where they go to communities and they're bringing other things, they're bringing other services. So beyond just bringing other health services, I think it's important to talk about the nutrition, to talk about the hygiene, to also talk about clean cook stoves.
Yes.
So
cook stoves.
I knew you picked that up. Yeah, and then also talk about the treatment. In Nigeria, I think Kit would know this. The simple thing as having oxygen in a hospital is not guaranteed. So these are the things that we should take for granted, but we're not there yet. And then, so I think that I'm a vaccine advocate. I mean, I work at IVAC and everything, but that will not stop me from saying that we need to look more broadly to addressing the issue of pneumonia.
Okay, we have, I think, a microphone. Sorry, there are bright lights here that is traveling. So anybody who has a question or a comment, please feel free. Here we go. And please identify yourself, and remember that there are people behind you also. So, yeah.
I've been told I have to stand up and I have to mention my name. So I'm Matu Santosham from IVAC at Johns Hopkins. First of all, congratulations for putting together such a very, very impressive panel. I'm truly impressed. So I just have a couple of comments and a question. First, I think we are at a very exciting stage in public health. I'm probably the oldest person in this room. And when I started my career 40 years ago...
And one of the most venerated, I might add. Your name was one of the first given to me if you want broad expertise, particularly on enteric disease.
When I started my career 40 years ago in public health, there were 20 million deaths each year. And we used to say at that time, diarrhea killed more people than pneumonia. One death every 6 seconds from diarrhea, and one death every... I think we were competing 10 seconds or 8 seconds for pneumonia. We've come a very long way. I think I agree with Keith. I think it's a question of whether the cup is half full or half empty. I think the cup is really half full. We should be tremendously grateful to the Gates Foundation for what they've made possible. I still remember going to the health secretary in the Indian government in 2001 saying, "Sir, I think we should introduce Hib vaccine." And he looked at me and said, "Dr. Santosham, you're dreaming. I have districts in UP that have 10% coverage, and you think I can introduce the Hib vaccine? It's ridiculous." And and I just walked out of the room. There's that old Jim Reeves song thinking, dream that impossible dream. And now we're not even talking about HIP. HIP is taken for granted. It's in every single country. So we can do it. When we put our mind to it, we can do it. And I completely agree with Chizoba. I think the treatment aspect is just as important as pneumonia. Let us not forget, we need better vaccines. And I think Keith and his group are working very hard on vaccine development. But we have interventions that are superb. We need to make sure there's coverage for treatment. And the PCV13 and PCV10, there are superb vaccines. So finally, I want to end with a question for the panel. Any of you, I think either Keith or Cindy or Samir can probably answer this. I always think of vaccines, we always think about vaccine preventing pneumonia, rotavirus preventing rotavirus diarrhea. But what evidence do we have that beyond preventing that specific disease, what are the advantages of the vaccine? Does it do anything for later growth and development, for education, or economic development? I would love to.
Just in case people in the back had a little harder time hearing, if I understand your question correctly, it's beyond the obvious prevention of infectious disease. What other advantages may there be to putting vaccines into human bodies?
Thank you for putting words in my mouth.
So thanks, Matu. So I want to pick up firstly on this enormous burden of mortality, which you alluded to, of a kid dying every 6 seconds. So it's World Pneumonia Day, as I said, next week, and we just had a convening in New York. And so the good news is that a kid dies of pneumonia now every 2 minutes.
2 minutes.
Yeah.
That's
that means
the
while
good
we've
news.
been sitting
Wow.
here,
Yeah.
how many kids have died of pneumonia? So it's still not acceptable. But I absolutely agree. I think we can do more. There are benefits of vaccines, as Cindy alluded to, that kids who don't get pneumonia or diarrhea do better. They could grow better. We need more data on this. There's some data that support this. We need to look at it. There's a whole world out there of antibiotic resistance, and vaccines can prevent antibiotic-resistant infections. At the same time, I want to go back to the point that was raised about what kills babies. And in fact, undernutrition is a huge killer in pneumonia. So we spend 80% of our money on prevention because we believe prevention is better than cure. But the rest of it does go in pneumonia to trying to do two primary things. One is to understand how undernutrition kills babies and how can we intervene to stop malnutrition so that babies don't die from pneumonia or diarrhea. In fact, we've joined our money together with the diarrheal team, and we focused on this vulnerable child because they really have an outsized mortality. And then more specifically around pneumonia treatment, we agree that oxygen is entirely a life-saving commodity, and it's very little available. And there, believe it or not, you can just make oxygen from the air. The problem with that is you need electricity, and electricity is not a given. So there are all sorts of complexities to this, but it's very interesting to us, and we are trying to help in that area as well.
So I layered with Mathu's last question that how the vaccine will be helping. I mean, vaccine will be helping in a lot of non-vaccine preventable diseases as well. One of the examples we are really now working on, the many large hospitals in the developing countries are really, there is a very fierce competition for the bed. A large number of children or newborns are getting refused when they are coming to the hospital because beds are full. And those beds are full by the diarrheal diseases, which can be prevented by rotavirus. Those beds are full by pneumonia cases, which can be prevented by pneumococcal vaccine. And more importantly, maybe in near future, if you get the RSV vaccine, it will be more obvious, in fact, we'll be seeing the differences. If we can do that, we looked at this. So in my hospital, where I work mainly, 6,000 babies refused last year. And large proportion of them birth asphyxia and premature babies. Those babies are really, if you delay in treatment, they'll be dying or becoming disabled. The large number of cases are very severe pneumonia. Those children really could not get the bed. If you can really prevent those diseases, the beds should be open for those cases which may be not vaccine preventable. But they will be getting the space, getting the treatment in time, and the life will be saved. That will be one very, very important thing, in fact. So look at maybe next, or maybe online, the American Society of Tropical Medicine Hygiene Journal. you'll be seeing that how we really showed
So
that.
I've seen your study already, Samir, and I really like it. And Matu, this is a rotavirus vaccine that Samir is arguing could save pneumonia deaths. So that's a virus against diarrhea, but by stopping the wards being filled with diarrhea patients, patients who would otherwise die from pneumonia could prevent the death. So that's really
And one
cool.
of the things that Samir has been very eloquent on is, along with all of you, is the sequence of changes to a family when the child is either saved from a devastating disease or stricken by a devastating disease, because it rebounds out to family members, schooling, the mother's ability to leave the house to go get work, the broad income of the family. There are repercussions that go way beyond just the difficulties of that particular child.
Yeah, and if I could just add, I think also when there's a vaccine campaign or when a mother brings her child to some of these clinics in more rural areas, it's also an opportunity to talk about nutrition, to weigh the child. So there are many benefits, and I'm so glad you brought that up, that aren't just the vaccine in the arm or the polio drop in the mouth. It's really an opportunity for particularly mothers living in more rural areas to get some education, to be able to have their baby weighed, to be able to learn about other resources in the community for her and her children. So there are many what we would call ripple effects.
Do we have other questions? I saw a hand raised back here.
Hi, thank you. Excellent panel discussion. I'm Karen Callender from Malaria Consortium, and
It's a little hard to hear up here, so if you could hold the mic as close as you can and just
speak up.
right there. Perfect. There you go.
Thank you. My question is about what you think is going to be. I haven't read the article yet, so I might sound a bit ignorant. But what do you think is going to be the next generation vaccine after the 13-valent? And what is going to be the limiting factor in terms of how many serotypes we can put into these vaccines? Is there a point where we reach saturation and you can't squeeze more in, basically?
These are the gentlemen to answer that question.
So the answer is we don't know what the limit is. It will probably be at least 20 or more. Ideally, there could be a really inexpensive vaccine that protected more broadly. And we are actually funding just such a vaccine. The problem is that the bar has been set very high. And the bar is set high because of what Cindy said at the beginning, that the current vaccine actually interrupts transmission. And when the strains disappear, the vaccine effectively becomes 100% effective in preventing disease in children and in adults. So the alternates to the current generation of vaccines, which just protect against the individual strains, we do need, if we get a new vaccine that protects against every pneumococcus, it also has to protect the whole community, and that we haven't found yet. But the search remains to try and come up with a very broad vaccine that could be more broadly protective. But I don't want to understate the value of the existing vaccines, which thankfully through Gavi, which we haven't really talked about, so there is this extraordinary organization that is able to offer countries vaccination. It's a deal with the country. The country has to promise to roll out the vaccines at a decent level of coverage. So there are some issues in Nigeria. But by and large, there's been extraordinary rollout of this vaccine, and it is saving lives.
I'm glad you brought that up, because the present model that is working better than anything in the last 20 years, according to all of the folks I talked to, is this model of Gavi, formerly known as the Global Alliance for Vaccines and Immunization. Now it's just called Gavi. It doesn't stand for anything anymore. Gavi relies, as most of you probably know, on a combination of philanthropic and governmental funding to provide enormous support and work directly with private companies. There's a certain political critique of this model and also a lot of support for it. The other phenomenon that was raised a lot to me as a possible change in the funding pressures is developing countries coming up with their own vaccine manufacture. Yeah. Right now, as you mentioned earlier, there are only 2 companies in the world making pneumococcal conjugate vaccines, the one appropriate for children, and they're both big multinationals. They've committed to relatively low prices, but but there are a number of organizations that would like those prices to be lower. So I don't know whether there's any companies that are underway in Nigeria, but can you speak to the possibility of real competition coming to the multinationals from developing countries? You have a look on your face like I have a strong feeling about it.
Well, there are some working on it, and some are definitely closer than others. And Keith would probably have more scoop than I do, but yeah, exactly. Serum Institute of India is one that I always hear as being pretty far along, and they're definitely interested in supplying a developing country market. They are
at a much lower price.
And they are the world's largest vaccine manufacturer. So they are, very promising. And I don't know if, Keith, you want to add anything about others?
Yeah, so certainly India now is producing more vaccines by volume, not necessarily by price, than any other country.
Right.
And so we are interested in China because we think China could step up. At the moment, there are very few vaccines coming out of China for the global market. But I'm happy to announce that there is another bug very similar to the pneumococcus, but instead of causing death in older children, it causes death right at the time of birth, and it's a similar organism. It's called GBS, stands for Group B strep, and that vaccine, we have made 2 investments. This is in the public domain. One is to a large pharmaceutical company, but the second is we're going to try and make a vaccine in Africa for Africa. So we have made an investment of $30 million to try and make for the first time a new vaccine in Africa at the same time that it's being made in the developed world.
Where in Africa?
So the actual manufacturing facility is in Cape Town, so it's in South Africa. But our mission to them is that if they make it, they have to make enough vaccine for the whole of Africa, and it has to be affordable.
And so you have some say in what affordable means?
We do.
Okay. Yes.
So, Cynthia, I want to add to that. In terms of local vaccine manufacturing, that has really increased in terms of aspiration. I have to tell you, in Nigeria and in other parts of Africa, there is the Minister of Health of Nigeria about 2 or 3 months ago signed a memorandum of understanding with May & Baker, which is a well-known pharmaceutical company, but not known for vaccine manufacturing.
A Nigerian pharmaceutical company?
I think they're global. May & Baker, M&B.
Okay.
It's global, right?
Okay.
Yes. So they have a memorandum of understanding to use an existing, or at least use facilities or assets from existing vaccine manufacturing. Nigeria used to produce yellow fever vaccines previously in the 70s and 80s, I believe, and somehow that stopped for some reason. So they want to go back to it. There is a lot of interest in local vaccine manufacturing because as a country, we spend a lot on buying vaccines. And so people are looking at it not just as a health issue, but also potentially an economic issue.
Yes.
So if there could be support to build local capacity to do that, they could start with the little vaccines, the less complex ones, and then build it out. There could be job creation. There could be so many other repercussions. But that also, there has to be caution about it because vaccines are, biologicals, and we want to make sure that if it's produced, it's produced right, and we don't shoot ourselves in the foot and reverse all the gains. So those are the 2 different forces that are actually playing out right now in conversations within Nigeria.
Good. We have time for 1 or 2 more questions. If anybody wants to hold up a hand, here's a gentleman in front.
Okay, we also have a question from Twitter.
Oh, okay.
Let's come in from
we'll
Laz Udeeze, who asks, from experience, what's the most important determinant of access to pneumonia vaccines in resource-constrained communities?
What's the most important determinant of access in developing communities?
In resource-constrained communities.
Resource-constrained communities. That's an interesting question. Dr. Whitney?
Well, for a while it was supply, for sure. I'm not sure what it would be now. Obviously, education of mothers is a big, important component. There's been, a lot of research with vaccines that show that, maternal education is associated with better knowledge, the knowledge that you need to go get these interventions for your baby. What else?
I mean, the care seeking, improved care seeking.
Yes, improved care seeking, right.
So that's critical, as you said, and the biggest determinant is socioeconomic, and it's access to care. So the same things that drive ability for the baby to get access to care if they get pneumonia will be problems for them getting the vaccine. But there's good news, and that is that the vaccine we've been talking about all evening, and we did talk about it protecting the elderly, it also protects unvaccinated kids. So here's the rub, though. You need to get enough of the community vaccinated. And for some diseases, such as measles, it has to be very, very high. You need 95% of the kids to be immunized to stop the transmission. For the pneumococcus, we believe it's actually quite a lot lower. It's nowhere near as low as 3% or 33%, but it is probably around 50 to 70% coverage, which is easily achievable across the board. So there's still some issues. There could be local areas where the coverage is lower, but WHO in general tries to have 80% coverage in all districts, and that would be more than enough.
Let's just see if we can get one more question in here before. Please, sir.
Not working? Yeah. So I'm Brad Gessner. I'm with AMP, University of Maryland, and most recently Pfizer. But I had a question on talk is on affordability, or most of it. Affordability, children, and resource-poor settings. I'm all for that. I'm a pediatrician who did most of his work in Africa and don't really like adults, so that's all good. But I think most of the unvaccinated kids, affordability is not the issue. They're not in resource-poor settings, and then there's a lot of disease in adults. So China, I think, the combination of China, India, and Indonesia make up most of the unvaccinated children for Hib and pneumococcus, and that isn't really related to affordability. So I wonder if you could discuss that and how you overcome the barriers in those countries where they could afford it. They're just not doing it. So I think China, it's 3% coverage for PCV, 50% coverage for Hib. And then also what the various groups are doing to create adult platforms where there's adult disease that won't be addressed just by vaccinating children.
So that was a hefty question that we could spend another 45 minutes on, and we won't because it's almost 6. So if we could just get the beginnings of an answer to his question, that would be very good.
So Brad knows that, in fact, this is a really weird situation we're in now. Traditionally, the poorest of the poor countries have been the last to get life-saving vaccines. And thanks to Gavi now, this particular vaccine is rolling out more in the poorest countries. So there are some very big countries that haven't yet rolled out. The one thing that I think we can do is to stress what we've talked about here. And so for a country like China that's grappling with a lot of problems of outdoor air pollution and a lot of pneumonia in their elderly, if we can convince them that by vaccinating their kids they would be protecting their elderly from pneumonia, that would be a lever to get the vaccine introduced into a country like China.
And as I said, we could spend a whole nother session, a whole extra session on that very thoughtful question, but we're coming to the end of our time. So I will take this opportunity to thank everyone who's here and also to thank everyone at the conference for your continued study and hard work on these crucial issues. Thank you very much.